Invite Dr. Karthik from Karthik Netralaya, Bangalore, for his talk on combination therapy in DME. Over to you, Karthik.
Hello. Very good morning. At the outset, I would like to thank Dr. Manjunath for making me a part of this IC at AIOS2025. I'll be speaking on combination therapy for DME, mostly looking at what kind of evidences we have to say whether combination therapy with more than one agent really works or it doesn't. So we are all aware about the multiple ways in which DME is treated, and most of the patients we do offer some form of combination therapy or not. So why do we do that? We anticipate that combination could improve the treatment outcome. It could reduce the load of treatment, the treatment burden. When we see that monotherapy isn't giving us what we anticipate to see, or when the disease itself has more than one pathomechanism which is causing the disease to progress or to persist. So one of the commonest thing that we do in our OPDs is to prescribe an NSAID for a patient with DME. So is NSAID beneficial? So there has been a meta-analysis which has been on the Cochrane database, which shows that as a solitary agent, an NSAID has no benefit in treating patients with diabetic CME. But also, patients who have undergone panretinal photocoagulation, nepafenac or ketorolac, has been does help in stabilizing the visual acuity and preventing a progression in the central macular thickness over a period of time. But please do understand that most of these studies have used nepafenac or ketorolac for a duration of as long as 6 months, 3 times a day, which we hardly do in our practice. So most of our practices, the nepafenac or the NSAIDs are given for at the max a month or 2 after the laser. So these studies have prescribed topical NSAIDs for a prolonged duration and seen some kind of a benefit. The next interesting thing that I came across was prescription of aqueous suppressants in patients who are undergoing anti-VEGF injection. So the thought is that you reduce the amount of aqueous that is getting produced, you reduce the recycle time of aqueous, and that is known to increase the duration or the longevity of the anti-VEGF within the eye. Now, does this really work? There have been studies, but most of these studies are very short duration studies. Some of them have reported benefits, some of them have reported no benefits. But I think it is something that it is very individualistic. It is not a very common practice for us to prescribe aqueous suppressants for patients who are taking anti-VEGF. But it may be considered in patients who have had vitrectomy and who are not fit to take a steroid implant to try to prolong the effectiveness of the anti-VEGF. What about all the nutritional supplements? Every other day we have people coming us and asking us to prescribe omega-3 fatty acids, vitamin D for patients with diabetic macular edema. So does it really help? Yes, there have been enough studies which has shown that vitamin D supplementation or high quality omega-3 fatty acid supplementation does help. But again, the response is slow. It is not that we start prescribing and we would expect a response like an anti-VEGF in a month. It is a period of 3 years, 4 years that we see some kind of a response. So we may have to persist and prescribe, especially in patients who are having deficiency in these things. Now, laser and intravitreal anti-VEGF injection has been studied extensively. The READ, the RESTORE, the Protocol I all have shown that a combination of anti-VEGF with the laser has a superior outcome as compared to solitary laser treatment. This fact that the DRCR Protocol I showed that 40% had limited response has been mentioned by my previous speakers. So there have been studies to follow this up, to follow up whether we should add a drug in these instances or whether we should continue. So it has known that whenever we introduce a dexamethasone implant in these patients, it definitely improves the macular morphology. But unfortunately, it has not been shown to have any superior effect in terms of visual acuity as compared to anti-VEGF monotherapy. So though the OCTs look better, the patient does not read better or the patient does not see better. Now, so does combining anti-VEGF with steroid really help? Again, there is a Cochrane meta-analysis which has looked into this. And most of the things wherever this combination therapy has been quoted, many of the places the OCTs always look better, but it does not equally reflect in the vision getting any better. The same with a combination with another anti-VEGF like aflibercept and triamcinolone acetonide. Again, the OCTs look better, but the vision is not very good. What about the inflammatory biomarker? I think Dr. Saurabh has mentioned about it. So morphologically, when we see on the OCT if there are HRDs or if there are sensorineural detachments, substituting a steroid in these instances definitely help to make the macula look a lot more better. So there is a significant morphological change, but again, when it comes to visual acuity, unfortunately, the visual acuity between anti-VEGF monotherapy versus a combination therapy with a steroid and an anti-VEGF does not seem to show a significant improvement. However, the combination therapy arm did have an early recovery compared to a monotherapy arm. Refractory DME has been discussed previously. So a substitution or not a substitution, an inclusion of a steroid in these group shows a good response in patients who have had SNDs. But when there is a tractional component developing like an epiretinal membrane or when there is a vitreomacular traction, the response does not seem to be adequate. Now, steroids can also be given in other forms, like we are starting to give suprachoroidal triamcinolone acetonide. We were giving posterior subtenon. So do they really help? So there are studies which has looked at suprachoroidal triamcinolone acetonide in combination with anti-VEGF drug. So most of these studies are short duration studies, but they have definitely shown one thing is that the need or the requirement or the load of anti-VEGF injection has definitely come down when patients whom we are giving suprachoroidal triamcinolone acetonide. Periocular steroids with lasers has been evaluated as one of the DRCR protocol, but it has shown that steroids in combination with laser showed no significant change in visual acuity or CMT between the groups. So when we are treating more than one pathology, so we are treating the PDR component along with the DME component, is there a role for anti-VEGF? Yes, so when we are giving treatment for these, then it would be preferable that we give a combination therapy in these instances in terms of PRP along with an anti-VEGF or a PRP along with a steroid. The thought being that the process of PRP itself is pro-angiogenic. So it releases VEGF which can worsen the diabetic macular edema. So in these instances, a pre-treatment with an anti-VEGF definitely helps. Does combining micropulse laser with anti-VEGF help? So it did not improve the BCV or CMT, but it definitely decreased the load of injection. So somebody who is prescribing or doing micropulse may see themselves giving a lesser number of injections when compared to a person who is not doing it. Targeted PRP has been spoken about by Dr. Manjunath. So earlier were thinking that the peripheral ischemia actually promotes macular edema, both in RVOs and in DMEs. But now this has been proved incorrect. So there is no role for targeted PRP, and PRP is only suggested when there is either a neovascularization or the other high-risk characteristics of a PDR. The other question is, does vitrectomy help in reducing the diabetic macular edema? So this has been in non-tractional diabetic macular edema. So tractional diabetic macular edema is treated with vitrectomy, but in case of non-tractional diabetic macular edema, does vitrectomy help? So there have been studies which have looked into treating chronic recalcitrant diabetic macular edemas with vitrectomy. But most of the studies show that morphologically the OCT looks better, but visually there is not much of a benefit in recalcitrant. But there was always this debate as to we are intervening very late. By the time we intervene, the damage has already happened. So should we intervene earlier? So in the UK, there was a multi-center trial which looked at treatment-naive patients who underwent vitrectomy for diabetic macular edema, which are non-tractional. And the results were quite surprising, and it showed no superiority of the vitrectomy over anti-VEGF injections, even in treatment-naive population. So this was something that was interesting. So to conclude, so there's not much role of topical solitary NSAID treatment in DME, but definitely can be prescribed for post-PRP cases. I'm sorry, post-PRP patients. Monotherapy with anti-VEGF or steroid is superior in terms of visual recovery, though the morphology does improve. Combination therapy with steroid has no evidence that it really helps. Therapies like subthreshold laser, suprachoroidal steroids do help in decreasing the load of anti-VEGF injections, but in terms of visual acuity, both of them fare almost equally well. And vitrectomy has a limited role in the management of non-tractional diabetic macular edema with or without anti-VEGF and steroid. Thank you very much.
Thank you, Dr. Karthik, for such a confusing topic. He made it very interesting. So I just wanted to ask him whether you want to try a combination therapy first, or whether you want to switch the molecule before trying for a combination therapy. Meanwhile, I request Dr. Sripati to prepare for his presentation. Yeah, Dr. Karthik.
So I think it would, I would usually try to switch because steroid and anti-VEGF haven't shown, though the response after the first injection of steroid is really good, but over time I think the repeated anti-VEGF injections do achieve almost a similar kind of effect. And what we are trying to see is how much of vision is improving. Morphologically, the OCTs do look better after we do a combination therapy, but unfortunately the vision doesn't seem to match with that kind of recovery in the OCT scans.
Yeah. Okay, thank you. Sir?
Yeah, I have been pestered by my medical representative to prescribe glow eye since many years, but I have resisted him. So you said we can give supplements for 2 to 3 years, then it may help. So which supplement do you recommend?
So what has been studied is one is vitamin D, sir. So, but there you can look at serum vitamin D titers and then see if you need to supplement in those reasons. Okay. The other thing is good quality omega-3 fatty acids is known to help such patients on the longer run. Okay. But again, we'll have to consider the cost to treatment because most of these patients are already on very expensive medications for their systemic management. So that is, and again, there may be a duplication of treatment. Many physicians also do prescribe multivitamins, multiminerals to such patients. So that is also something we'll have to look at.